meeting. We're happy to have Dr. Rita Bell Fernandez present on Dementia Basics, Part 2. This is normal aging versus dementia. Dr. Rita Bell Fernandez is an associate professor at the Geriatric Medicine Department of the John A. Burns School of Medicine, University of Hawaii. She is a practicing geriatrician at the Kalihi-Palama Health Center and also a medical director at Bristol Hospice. Dr. Fernandez has served on the Doctors Work Group for the State Task Force on Alzheimer's disease and related dementia. She's also a co-principal investigator of the Hawaii Alzheimer's Dementia Initiative, a grant from the Administration for Community Living, and she's a certified regional trainer for the National Task Group on Intellectual Disabilities and Dementia Practices. Dr. Fernandez has championed memory clinics across the state to provide comprehensive dementia care. She did a great presentation last week for those of you who were able to join us. She's going to show 2 videos kind of to recap what happened last week. And I'm sorry the recording from last week didn't get recorded, but we did a presentation on Saturday, and we will be posting that presentation up on the Alzheimer's website for EOA. And it has a lot of the same information, but it has a lot of tools for caregivers. So it was a really nice presentation, and I'll send you guys the link. So Rita Bell, take it away.
Aloha, everyone. Good afternoon. Thank you for joining us on this Zoom meeting. My sincere apologies. I'm new to Zoom and presenting on Zoom, and last week I had not hit the button check on the computer audio. So I'm so sorry you all never got to hear the video, and I would like to start with the video because it is going to recap all that we learned last week on dementia and what is Alzheimer's disease. So let's watch this video.
What is Alzheimer's disease? Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination. And in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady, and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure. Thanks for helping to do your part. Learn more at www.aboutal.
Okay, I hope you got to see that video and hear it clearly. You can let us know in the chat box if the video was clear and you could hear it. There is another video in this part 2, and we have done a test run this time to make sure that we're good to go. So my apologies for last week. So let's go to part 2 of the training. We are going to talk about taking action and what each and every one of you can do in your role in the healthcare field. So how is dementia diagnosed? There is no single test to diagnose Alzheimer's disease. Now think of diabetes. If I want to know, do I have diabetes, I can get an answer today. I can get an answer within 24 hours if I have diabetes or not, because you can do a fasting blood test, they can poke your finger, they can check an A1C. If you're pregnant, they make you drink that orange juice and they test your sugar over 3 hours. So there are many different tests like glucose tolerance test, the A1C, the blood test, and you can get an answer whether you have diabetes or not. With Alzheimer's disease, it is very tricky because it is a rule-out disease. So essentially, the provider has to do a whole bunch of things and look for like treatable causes of dementia, like low thyroid or a B12 deficiency, check for HIV, syphilis, all the rare things. And if everything comes back normal, then the provider will say, oh, I think your loved one most likely has Alzheimer's disease. So it is a whole host of physical examination, neurological examination, cognitive assessment, blood tests, maybe brain scans, maybe get a functional assessment. Maybe some people need neuropsychological testing. So it's a combination of everything that leads to the diagnosis. Right now, Alzheimer's disease is still a clinical diagnosis. So what can you do in your role? And here is where we come up with the cognitive assessment. Because what is happening today, doctors and nurse practitioners and physician assistants, they're in a busy practice of just 15 minutes per person. They often don't have the time to do these cognitive tests. So we are taking this upstream and bringing it to other healthcare professionals, maybe as a case manager, as a social worker, as a nurse. You could administer the test. So let's look at what are these validated tools. They are supported by years of research. That means when they do studies on a tool, they look at so many different populations, they look at big sample size, and then it comes down to what are the factors that are most important in early detection. And that's how you come up with a validated tool. So please trust the tools. There is no room for creativity. It's not like American Idol where you go take that song and make it your own. You can't make it your own. You have to just follow the tool exactly like it is. So tools have been shown to improve detection. Now look at this graph. See, the Mini Cog is in green and the patient's own physician is in gold. Look at, by the time the patient's own physician detects dementia, it's quite in the severe stage or moderate stage. But if you look at the tool, the green bars, it can catch dementia early. It can also catch mild cognitive impairment. So tools improve detection. So some general things when we are doing cognitive testing. The first thing is, please don't tell anyone you are going to administer a test. Because if we say the word test, it's like a bad word. Like hospice is another bad word. So if you say test, then people get nervous, anxious. So we don't want to say that. It's a very nice sentence, and I want you to repeat after me. I know you are all muted, but please repeat this sentence. we're going to do something next that requires some concentration. Let's repeat it again. We're going to do something next that requires some concentration. And that is a very nice way to lead into you're going to do a screening test. So do not allow people to give up prematurely, because sometimes when you're administering a cognitive test, people might get frustrated or embarrassed or irritated, and they just want to stop. So you don't want them to stop. You want them to, oh, it's just a few more and we'll be done soon. You do not want to deviate from the standardized instructions. You gotta offer, you do not want to offer any hints, okay? And I know this is hard because we all in the healthcare field, we're soft-hearted, we love our patients. There's no giving them hints or helping them. And you do not be soft on the scoring. So if the score is 0 or 1 or 2, don't make 1.5. Don't make half point here, 3/4 point there. You have to score it exactly the way the tool is telling you. Remember that these tools are not diagnostic. So there are many reasons why somebody may not do good on a test that you administer. And that's because they could be tired, maybe they didn't have a good night's sleep, maybe they have a pneumonia or bronchitis, they're sick, maybe they're depressed. So we cannot tell a family, I did this test and your loved one has Alzheimer's. We cannot say that because these tools are not diagnostic. They're only helping us to screen for memory deficits. So the purpose is to identify people with cognitive impairment so a workup can be done to identify a cause. So what you are doing, you are getting the ball rolling. You are starting the process, because otherwise 6 years could go by and no one will know anything any different. So thank you for your willingness to screen and administer the tool. But remember, the tools are not diagnostic. Now, there are two types of screening tools that we're going to discuss today. And what I would like you to do is look at the handouts that Debbie sent, and please open the handout. There is a PDF file called 88, and there's another file called the Mini Cog. Preferably, if you could print this out, this will be great, because then you can make notes on the paper itself as I go along. It's of value to take your notes on the tool, because you might not come back to this PowerPoint and this PDF. So remember, there are two types of screens, and follow along in the screen as I'm going to explain them. One is the 88, and the 88 relies on a person's opinions, insight, and observable skills. It can be administered to the caregiver or the patient. It is less reliable because it is a subjective tool. Now, an objective tool, a better tool, is the Mini Cog, because it's a direct measurement of a client's brain function. It is more reliable. Now, when you're going to choose which tool, like, I don't know when to choose what tool. Now during COVID-19, we are all stuck in the house, right? Most of us are working from home. So you might say in COVID-19, I'm going to do this over the phone because I'm not leaving the house. I'm not exposing myself or exposing the other person to me. So if you want to administer over the phone, the 88 is very useful. It can be administered with an informant, a caregiver, a family member, a friend, or you can administer it directly with the client. Now, if you are in person, if you're doing a home visit, or you are in an assisted facility, a foster home, a care home, a nursing home, you're in person, then you can do the Mini Cog with the client. You could also do both. If you want, you can do the 88 with an informant if one is present. So I'm going to start by explaining the 88. Please follow along in the 88 handout that was given. So this is what it looks like, the 88 screening tools. It's only one page and there are just 8 questions. So it's not going to add too much to your work time and slow you down and all of that. it can be done pretty quickly. So remember, you can administer it to the caregiver or the client. Now, there are two ways to administer it. Either you read the questions out aloud and you get a yes, no, or you give them the form to fill out. So put it on a clipboard, get a pen, and say, could you please fill this out? And they can look at it and fill out the forms themselves. So if you're reading aloud, you got to say this. Please answer the next questions with a yes or no. Yes means there have been a change in the last several years due to problems with thinking or memory. No means no change has occurred. It's important to stress that it is due to problems with thinking or memory. It's not due to Nana had a hip fracture, so she's not going out and doing all her hobbies and things she used to do because of the hip fracture. We have to make sure that the change is due to problems with thinking or memory. So you would say, in the last several years, has Nana experienced problems with judgment? This is one way you could read out the questions. In the last several years, has Nana experienced less interest in hobbies or activities? You want to read the questions word for word. If the person changes the answer, you record their final response. Now, life is not so easy. I wish life was easy, right? You get a yes, you get a no. In reality, people may not give you a yes or no. They may say maybe. How are you going to code maybe? So if you get like in the middle of the road and they're unsure and they can't decide, give them a little more time and then say, would you say generally yes or generally no? You want them to lean on one side or the other. If a change has occurred due to physical limitations or problems, clarify whether any change has occurred due to memory or thinking. So it's important to understand that. Do not record answers related to a physical limitation. A physical limitation could have been a stroke, it could have been a heart attack, it could have been a hip fracture. You don't want to record change because of that. If the informant says they do not know or it does not apply to the person, record NA, not applicable. Sorry. So you are giving 1 point for every yes answer. Remember, there is no half point, there's no 3/4 point, no quarter point, 1 point, 1 or 0. So the most somebody can score is 8 points. So what is a pass on this test? On an 88, a normal of pass is 0 to 1 points. A person fails or is impaired cognitive impairment if it's 2 or more points. So if you get 2 or more points, please consider referral to a healthcare provider for workup. Any questions on the 88? You can enter it in the chat box. I'm happy to take any questions on the 88. If not, we will move on to the Mini Cog. So let's open that handout that Debbie has sent you. Please open the handout of the Mini Cog and let's follow along with the Mini Cog. So the Mini Cog has got 2 things. It's got a word recall, where you give 3 points, and the clock drawing, which is 2 points. So the client is asked to recall 3 words. It could be banana, sunrise chair. It could be leader, season, table. It doesn't matter which version you use. Client is asked to draw a clock and set the hands 10 past 11, and you get 2 points for that. Now, what are the advantages of the Mini Cog? It is quick. It'll take 2 to 3 minutes, not more than 5 minutes. It's easy to administer. It can be used in primary care settings. You could incorporate this tool in a primary care clinic, a family practice clinic, an internal medicine clinic, and it can be done by the medical assistants. So you don't have to have any fancy degree or qualifications to administer this tool. Anyone who is trained can administer this tool. It measures multiple memory skills, such as memory, spatial, and abstract reasoning. And this is important because a lot of us are familiar with the MMSE, the Mini Mental Status Exam. That's kind of what I learned in medical school. When I was back in Mumbai, India, I learned the MMSE, and that is 30 points. Now, one of the criticism of the MMSE is 10 points on orientation only. It's not giving up enough weight to other areas of dementia, whereas Mini Cog is giving weight to spatial, to abstract reasoning, and to memory. So this is what it looks like. And if you turn the page at the back, you will see that big circle, okay? So the Mini Cog has a front and a back. The circle is at the back. So what is the research done on Mini Cog? One is the performance is unaffected by education or language. So say if I'm administering this to a Marshallese patient, I can choose those same 3 words and tell my interpreter to say those words in Marshallese. So it's unaffected by education or language. The sensitivity and specificity is similar to the MMSE. So many of you in nursing school, social work school may have learned MMSE. This is as comparable. So it's short and sweet, but it's pretty good. It does not disrupt workflow or and it increases rates of diagnosis in primary care settings. So there's a lot of published studies on the Mini Cog. Failure to, if you fail on Mini Cog, it's associated with inability to fill a pill box. And that has been done, a study done by pharmacists. So how do we administer the Mini Cog? First thing is make sure you have the client's full attention. That's important because if they're not wearing their glasses, they left their glasses at home, their hearing aid is at home, they're not going to score well on the test because they can't hear you good, they can't see good. It's important that you have their full attention, they're not distracted or sleepy or tired or irritated. Then you got to select a word list. Versions 1 to 6 are all equivalent. It's not that this one is better than that one. It's whatever you wish to use. Now you must use version 1 or 2 of the, most choose to use that one. But remember to stick with the versions and don't come up with your own 3 words. It can be translated into another language as long as the meaning remains the same. Speak clearly and in a reasonable volume. It's important to speak clearly, face the client, because sometimes if they can't hear, they can read your lips. So face the client, make sure you have their full attention, speak clearly and in a reasonable volume. Then you get clients who say, what is this about? Why are we doing this? What's this survey? Why are you testing me? So the way to answer that question is, the purpose of these questions is to see how the brain is doing. It's our checkup from the neck up. So that just puts them at ease because they may be suspicious, like, why is she asking me this? Why are you doing this to me? Or you could say, we do this to all our clients. We ask this for everyone. And that then normalizes it. They don't feel like, why are you asking me only? So when you're administering this, you say, first you want to make sure they register the words. So please listen carefully. I'm going to say 3 words that I want you to repeat back to me now and try to remember. The words are, and then you say the words slowly, clearly, and do so like 1 second apart. You can repeat that list twice if necessary. If 3 attempts, then you just move on. But you want them to repeat it back to you. And why is that? You want to make sure they just registered. You're not testing recall. You are just testing registration and attention. Because if they couldn't repeat it back, maybe they didn't understand my accent. Maybe it's like, what is she saying? I didn't get what she said. So the reason to repeat the words back is to make sure you had their attention and registration and they got the words correctly the first time. If they didn't hear you correct or they misplaced a word or two, you can repeat all three again. So you can repeat the list twice if necessary. If they cannot repeat them back after 3 attempts, just move on. Now, after the client repeats all the words, do not remind them again that you're gonna ask them later. So you move on. After they say the 3 words back to you, you turn the page over because now you're going to the circle at the back. And you tell them, I want you to draw a clock for me. First, put in all the numbers where they go. So let them put the numbers of the clock. Sometimes people might just make little tick marks where the anchor numbers are. So you say, please put in all of the numbers where they go. If most of the numbers are present but missing some, don't prompt or repeat. Once they finish drawing the clock, then you say, now set the hands to 10 past 11. Now do not say 11:10 or any other deviation. Just say, please set the hands to 10 past 11. You can repeat this instruction as often as needed to make sure they got it. If the client cannot complete the clock drawing in 3 minutes, you move on. Often when people are taking forever with a test and not able to complete and you're getting irritated, that could be a sign of delirium. Delirium is they just can't follow what's going on, and maybe they have an infection, they have a UTI, you don't know. So if the mini cog is taking super long, it could be a sign of delirium. If in a mini cog somebody is just like, I don't know, and not even trying, maybe that person could be depressed because they couldn't even care to answer the questions. So once you finish the clock, you turn the paper back and you go, you're going to ask them, what were the 3 words I asked you to remember? And you have those dashes. Please write what they tell you. Whatever they say back, write it down. And if they say, I don't know, I write down, I don't know. That was their response. Whatever their response, you record the answers. Do not provide clues, hints, multiple choice. I know you love your clients, love your patients, but no helping them, no cues, no multiple choice, no prompts. Now, how do we score this mini cog? In the word list, you get 1 point for each word that they recalled after the clock drawing. They're not getting 1 point when they just repeated it back to you. That was just attention and registration and making sure they heard you correct and got your accent and got the 3 words. You are giving them 1 point for the words recalled after the clock drawing. So they can get maximum 3 points there. Now in the clock drawing, this is very interesting that the clock drawing is scored either as a 0 or 2 points. There is no 1 point for the clock. There is no 1.5 point for the clock. It's either all or nothing. They get 0, either they pass or they fail. So what does a 2-point clock look like? It has all the numbers 1 to 12 in correct location. You got to look where the anchor numbers are. Where is the 3, 6, 9, and 12? You want to make sure there's no missing or duplicate numbers. You want to make sure they have 2 hands present. One is pointing to the 11 and the other is pointing to the 2. Sorry, the length of the hand does not matter. inability or refusal to draw the clock is scored 0. So in Mini Cog, if they score 4 points or 5 points, it's a pass. If they score 0, 1, 2, or 3 points, it's a fail. So this is opposite of the 88. Yeah, 88, the lower the points, that's a pass. And here, here you fail if you're getting 0 to 3 points. You want to consider a referral to healthcare provider. So if there is a fail on the Mini Cog, you want to refer to healthcare provider for workup. So let's look at Colleen. Let's look at this example. Now, Colleen is a 66-year-old lady who presents to primary care with memory complaints. Her daughter complains that her short-term memory is poor. It began 1 to 2 years ago and is getting worse. She has history of low blood sugar, history of heart attack, repeated hospitalizations for atrial flutter. There's often frequent medication change, especially when you go in and out of the hospital. There's problems with medication changes and problems with her managing this independently. She used to be a retired accountant for the family business. She lives with her husband, who is running the family business, and now she's referred to care coordination. So this is a real patient. This is not an actor, actress, and we're going to show you a video of Colleen's Mini Cog. And this is done by Dr. Terry Barkley, and I've been presenting from his slides. He did the initial INR training. So for those of you who remember Dr. Barkley, you're going to see him here administering the Mini Cog to Colleen.
Hi, Colleen. It's nice to see you.
Thank you. It's good to be here.
It's been about 6 months, I think, since your last clinic visit.
Yes.
I understand from the nurse that you're here because of some dizziness that you've had recently.
Yes, I am.
Yeah, sounds pretty bothersome.
It is.
Well, before we look into that a little bit more, we're doing something new in the clinic, which is that just like the nurse was checking your vital signs, your pulse, your blood pressure, we're now also checking the health of the brain on a routine basis. Okay. And so I'm going to ask you some questions next that require a little bit of concentration. Sound okay? Okay. The first thing is I want you to listen carefully because I'm going to give you 3 words that I want you to repeat back to me and try to remember for later. Okay. You ready? Mm-hmm. Okay. The words are banana, sunrise, chair. Can you say those back to me?
Banana, sunrise. I don't remember the last word.
Okay. The 3 words are banana, sunrise, and chair. Can you say those
banana, sunrise, and chair.
Great. Now, I'm going to give you this piece of paper with a circle on it. And what I want you to do is make a clock for me by putting in all the numbers where they go. Now, Colleen, can you set the time so it says 10 past 11? Okay, I'll take that back from you. Now, what were those 3 words that I had you repeat earlier?
Sunrise, banana, shampoo.
Okay, great, thank you. Colleen, have you had any concerns about your memory recently?
Yes.
What kind of concerns?
That I'm forgetting a lot.
Okay. What kinds of things have you been forgetting?
Things that I'm supposed to do during the day that I normally do. Mm-hmm. Or like when I go into a room to get something, I don't remember why I'm in there. Mm-hmm. And then I start cleaning and doing other things. And then I remember what I went in for. And sometimes I don't.
Mm-hmm. That's really frustrating.
Very.
Well, maybe once we're done with today's visit, it might be a good idea to have you come back so that we can look into that a little bit more. Would that be okay?
Yes, that would be fine.
Okay, sounds good.
How did you like this video? It really helps to see the Mini Cog is easy to administer, and it can be done in a timely fashion. And Dr. Terry Barkley is such a natural manner to administer this test, such an easygoing manner, which helps the patients not to feel scared or frightened that you're administering a test. So let's look at Colleen's clock. What do you think Colleen should score? How should we score this clock? Do you think she gets a 0, a 1, or a 2? Colleen's clock is a 0-point clock. It's 0 point because clock drawing is all or nothing. What about the words? She got 2 out of 3 words, right? So she got sunrise and banana. And she gets 2 points for the word recall. So Colleen's Mini Cog is scored as a 2 on 5. Did she pass or fail this Mini Cog? She has failed the Mini Cog. So she requires further workup. Let's look at this clock. How would you score this clock? 10 past 11. So here, this clock would be scored as a 2-point clock because the length of the hands do not matter. It doesn't matter where the short hand is, where the long hand is. What about this clock? Yes, you're right. This is a 0-point clock. What about this clock? Here, the numbers are written outside the circle. Would you give this a 0, a 1, or a 2? You're right, this is a 2-point clock. What about this one? Person just puts an X. Is it a 0 point, a 1 point, 2 point? Very good, this is a 0-point clock. Look at this clock. Is this a 0-point clock, a 1-point clock, a 2-point clock? It is a 0-point clock. Thank you all for participating. Now this clock is a little tricky. This one, Dr. Barkley had to really explain to us when he did his presentation, that if you look at the anchor numbers, the 3, 6, 9, and 12, you see the person corrected for the 9, and even though it's a little crooked or not in perfect symmetry, this person would have been given 2 points. So this is a 2-point clock, though some people might argue and say, hey, maybe we should give this 0, but Dr. Barkley said he would give this a 2-point. What about this clock? This clock is a very nice clock, and you can see the 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Here, this is a 2-point clock. So thank you for participating in this exercise. Now, what if the scores do not agree? Now, say you had a lot of time. See, in this COVID-19, I have a lot of time. At the clinic, the productivity is so down. We don't have patients coming into the clinic. We have now lots of time. So if you have lots of time, you may say, hey, I'm going to do both. I learned these 2 tools. Let me administer both of them. Let me do the Mini Cog. Let me do the 88. What if a client performs poorly on one, fails in one, and passes the other? It doesn't matter. You need to encourage the client to see a healthcare provider if either the Mini Cog or the 88 yields an abnormal score. So what if the client says, how did I do on the Mini Cog? Did I pass? How did I do? So the best response is to say, you did just fine, which is great news. If the client expresses concern about their memory at that point, you can encourage them to talk about their concerns with their healthcare provider. You see, when we're administering these tools, the client is looking at our face to see whether they are doing good or they're doing poorly. So my response, I never say good job. I try to stay away from saying, oh, great, good job. Say, okay, okay. Okay is a very neutral word, so they don't know whether they're doing badly on the test or they're doing good on the test. And you want to stay in a neutral position simply because we don't want people to get nervous. Because if you start saying good job, then if you stop saying good job, they're going to get nervous and say, oh my God, now I'm doing really bad on this test. So be very careful of what your response is. What if they didn't do good? So here's a sample script. You could say, one area of concern is memory and brain health. There are many reasons why people might have trouble with their memory. You could name a few. Somebody could be tired, poor sleep, side effects of medicine. One thing we should work on together is making an appointment with your doctor so we can follow up on this. Seeing the doctor is important so we can figure out what's going on and how to keep you healthy. I want you to stay well. So please don't say, oh my God, she failed on the Mini Cog. I think she has Alzheimer's. Don't tell the family that. Don't say anything, because we cannot diagnose with these tests. So what would be your next step? You want to facilitate making an appointment with the doctor as much as possible, or as much as you can in your role, within your role. If you're a service coordinator from a health plan, service coordinator can help facilitate making an appointment. If you work in the hospital, in the transitions care team, many of the case managers, the transition care case managers, they help make that appointment. They can pick up the phone, schedule the appointment, arrange for transportation, all of that. Now, what's important is that the Mini Cog gets to the provider's office, because you could do all this wonderful work and make the appointment to see the doctor, and the client would come in and say, I'm doing fine, all is well, how are you doing, doc? So this could be completely missed, that the appointment is for memory problems or looking into the person's memory. So try to see if you can fax the 88 or the Mini Cog. Try to see if you can mail a copy to the provider's office. But somehow you want your hard work, your good work, to get into the patient's chart. It needs to get into the health record. If you give it to the client themselves and say, could you take this and show it to your doctor? What's going to happen if you give it to the client? They have memory problems, right? They may forget to take that piece of paper, and they could have left it at home, which often happens. They leave so many things at home and they forget to bring it to the doctor's office. So please don't depend on the client to take the 88 or the Mini Cog and show it and discuss it with a provider. If you have a caregiver and you feel this is a really reliable daughter, son, these caregivers are on top of it, they're going to make that appointment, they are fantastic caregivers, then you can certainly give it to the caregiver and say, could you share this with the doctor and make an appointment at the next visit to address the Mini Cog or the 88? So that's essentially the next steps. And I am done with my presentation, and we're happy to open up. You can unmute yourself, and Debbie can facilitate, please, the question answer. I'm happy to take any question and answers now.
Let me see if I can, I have to try and unmute everybody. Okay. Okay, I took you off unmute. Does anybody have a question?
Focus is exactly that with the minorities. Specifically, we look at patients. We are bringing our country back, and the big focus is exactly that.
Is somebody asking a question? Hello? Rita Bell, did you show the second video? Did you want to do the second video?
But let's
No question.
Debbie,
Yeah. What is it?
themselves, or type the question in the chat, otherwise we have too much background noise.
Okay.
So Debbie, you repeat the question that they're typing in the chat.
Yeah. Hold on. No. What does UTI cause? Why does UTI cause brain errors?
Okay, the brain error that you're seeing in a UTI is typically delirium. Delirium is a state of acute, there's confusion, inattention, they could have hallucinations, delusions, and you often see this when patients are hospitalized. A lot of people in the hospital, elderly patients, may get a delirium, so their brain is looking like they're so confused. Do they have dementia? But they don't have dementia, they have delirium or confusion. Like if you administer the Mini Cog to somebody in the hospital, most likely they're going to fail on your Mini Cog because they could have a delirium from a UTI, a pneumonia, etc. So the differential diagnosis for dementia are the other Ds. They talk about the 3 Ds. D for dementia, D for delirium, and D for depression. Don't be fooled by this, okay? It's easy to get fooled. Remember, a person could also be having delirium, person could also be having depression. So you want to treat the delirium or treat the depression and then look at the dementia. So when the UTI is over, when they have finished their antibiotics, you can do the Mini Cog or the 88 like a month later. You don't want to do it while a person is sick. Now, I forgot to mention to all the participants on this call today, I have homework. I do have a homework assignment for you all. We have 1 week between this session and next Thursday. So my homework is, I would love for you to administer the 88 and the Mini Cog on someone. It could be a family member, could be a friend, could be a church friend, could be your neighbor. You could practice the Mini Cog with your neighbor. You know, I know we're all stuck at home, but we need to practice this, because if we were doing a live session, a live training, we would have had a breakout groups to do and practice the Mini Cog and the 88. And we don't have that opportunity right now since we're on Zoom. So I would like to give you some homework for next week. You have 7 days to achieve this. Please administer the 88 and the Mini Cog on someone so you get to practice how it feels like to administer this tool. Thank you.
Any other questions?
Debbie, could you check the chat box?
Yeah, I am. Yeah.
Thank you.
They're just comments. Thank you. They may have to update the clock piece in about 20 years because so many clocks are digital. Yes, we know that. We brought that up to the Barclays too. One person said that she appreciated your comment about hospital and delirium because her grandmother was having problems in the hospital.
I'm sorry to hear that. Okay, you know, last week I did not get a chance to show the second video as well because, my apologies, I did not know how to check one little box that said computer audio, so sorry about that. But I could, since we have a little bit of time, For those who wish to stay on, I know those who are busy, you can sign off and leave the meeting. But those who would like to watch, I would like you to see this video.
Before you sign off, I'm going to send you a post-test evaluation for you to fill out. And if you are applying for social work CEUs, you need to complete the evaluation for me. Okay, thanks.
Okay, now this video is a beautiful video, and it highlights the importance of early detection. Because you might argue, what's the point of doing all this? Why do you want me to, screen or do this early? Because there's no good medicine, there is no cure, there is no vaccine. What's the point of it all? So I want you to watch this video.
I just didn't know what to do. I went up the escalator, I went down the escalator, I stood in the middle of the airport. And at that point, I felt like I was going to cry. I mean, it was just such an uncertain feeling. It was enough to say, okay, there is a problem. And I had said to my doctor about a year before that I did have memory problems and he and I needed to talk. But, you just sort of put the things off. He took a piece of paper off his pad and said, well, here, just draw a clock and make it whatever time he had suggested. And I didn't do it right. Shock of my life. I look at myself in the mirror and there's nothing wrong physically. It's in the brain. Some outright disputed the diagnosis and said the doctor was wrong. You say to the person that you have Alzheimer's and they go through the list of stereotypes. Well, you can't have it because you're too young, or you can't have it because, in fact, we're able to communicate. The earlier a person is diagnosed, you are able to put your own affairs in order. You're able to, and that's like your banking and representation agreements and, your legal affairs, your financial affairs. But you're also able to learn about your own health so that you don't, once you're diagnosed, you don't sit at home and sort of think that's the end of it. And it's been 3 years for me, and I have kept active. And the longer you ignore it, the harder it is, the harder it's going to be. The early diagnosis will make sure that family and friends understand why you are, repeating the same question. She's been very understanding, very helpful, very comforting. It's very comforting. Now when I go through airports, I arrive early and it's all very, very calm. It's a process, but it's all very, very measured. The earlier you confront it together, the more you're able to learn about it together.
Well, thank you. I hope you enjoyed that video. It's so moving, and it helps you understand the importance of early detection, the importance, what it means to families. And please note, you are doing a very, very important role. Each of you on this call, as part of becoming dementia capable and taking this INR training, you are part of the solution. You are going to help the ball rolling, get the ball rolling, get it started. Otherwise, it could be missed for years. So I thank you for taking the opportunity to learn about the ADA, to learn about the Mini Cog. And I want to thank you in advance because I know one day you will administer this to somebody and some family will thank you so much. So on behalf of all the people with Alzheimer's in our state and their family, I want to thank you for being part of the solution. Mahalo for attending today's Zoom session.
Okay, just a reminder to fill out the evaluation and post-test. And hope to see you next week. We have a part 3 next week. Same time, 1 o'clock, same channel.
Thank you.
Have a good week, everybody.
Bye now.
Bye.